for inviting us. It's a pleasure. It's always a pleasure and fun to speak with my dear colleague, Dr. Rosenow. So we put a couple of cases together from our experience in the last couple of years. They're all cases done by me and Dr. Rosenow to illustrate how we've used laser ablation and where we think what the suitable candidates are. But as a disclaimer, these are our cases, but obviously we are getting some honorarium from Neuroblade, and if you can read the indication for the Neuroblade system. I have a couple of disclosures which I don't think have any relevance to this talk, and I think the same applies to Dr. Rosenow. So stereotactic laser thermal ablation in the treatment of epilepsy is basically has the promise that it allows the elimination of the epileptogenic zone without the need of an open craniotomy, which is obviously very intriguing for many of our patients who or several of them have shied away from open craniotomies, and also for some of our referring physicians who obviously are much more intrigued by laser ablation. The benefit is that patients probably have a shorter hospital stay. They usually leave the next day. There's reduced collateral damage just to get the trajectory into the hippocampus. And also some neurocognitive studies showing that there's less neurocognitive decline from the procedure. And it, as I said, it has become an option for patients who were not considered before for surgery for a variety of reasons we talk about. It has obviously disadvantages. There are studies showing that if you look at larger series, that the chance of becoming seizure-free is probably 10–15% lower than in patients who choose a larger resection. And there have been some early studies, at least, indicating that that the risk of postoperative complications, so visual field defects, hemorrhages, and other things, could be similarly as we see it in an open craniotomy. The indication and the areas which laser has been used is mainly driven by the kind of configuration of the anatomical lesion, and also by the congruence between lesion and epileptogenic zone. So patients with kind of ill-defined focal cortical dysplasia are probably not good candidates, but people with clearly defined hippocampal sclerosis, people with cavernous malformations, hypothalamic haematomas, low-grade gliomas, assuming that they don't have any secondary focal cortical dysplasia, and patients with periventricular nodules are often ideal candidates for laser ablation. But there are also patients with specific epilepsy syndromes like mesial temporal lobe epilepsy, even in the absence of a lesion, as long as you are able to prove that the origin of the seizures is the hippocampus or the amygdala, can be amenable for laser ablation. And then there are patients where the anatomy of for example, the corpus callosum allows you to disconnect with using 2 or 3 well-planned trajectories without having to do an open resection. So we're going to talk about 4 and potentially 5 cases. So the first case is a relatively classical indication. So this is a 56-year-old identical female who has epilepsy all her life. So she has a feeling of deja vu and knows that she's going to have a seizure, and passes out and stares and has automatisms. She has very frequent seizures. The family is quite concerned about her, but for her, she never really considered doing an open resection. And obviously also for a long time hasn't been told that she has temporal lobe epilepsy. She has a relatively classical neurophysiologic findings. She has mid-temporal sharpness, as you can see on the left side, and then on the compressed 22nd page, you can see the rhythmic activity over the left temporal region, indicating her left temporal lobe epilepsy can be recorded for typical seizures. The neurocognitive examination is, a little bit below average, with maybe some mild retrieval issues indicating a dominant temporal lobe epilepsy. And she has imaging findings consistent with hippocampal sclerosis. So these are obviously ideal candidates. There is a clear-cut pathology. She probably has a couple of alleviating factors to make any kind of risk for postoperative cognitive decline to reduce that. And she is someone who has not considered surgery before and was quite open to laser ablation. So these are the options. You know, you could say, you could offer a left temporal lobectomy. The Germans do a lot of selective amygdala hypocampectomies. We talk about laser. In some patients where the risk of memory decline is higher, one could consider an RNS implantation. Or obviously, you could also say 56 is too old for me to do any of these surgeries and offer the VNS system, which I personally don't think is the right thing to do. So I think as I said, this is a relatively clear-cut case for laser ablation. Maybe Dr. Rosenow, you can comment a little bit on the imaging finding we see here post-ablation.
Yeah, so as Stephan was going through this, right, this is a relatively standard, case of mesial temporal epilepsy, but you can see the number of options that are available with, laser ablation being one of them. Obviously, we chose laser ablation, in consultation with the patient. But I think part of what we're trying to show today is kind of where laser ablation fits in the spectrum of epilepsy treatment. We all come at epilepsy surgical decisions from different points of view. So I think it would be interesting to hear what everybody would do in their own centers with this case. So what you can see here is this is a delayed postoperative MRI showing the ablation area. One of the things I think that we've been doing over the years since we started, and this patient is almost 3 years out, is I think we've started to become a little more aggressive at how we handle the anterior part of the ablation, especially the area around the front of the amygdala and the temporal pole, trying to get as much of the amygdala as possible. You can see in this MRI, we probably didn't do as good a job as we could have at that point. I think this was 3 years ago. I think we were just still more on the complication avoidance and less on the pushing the envelope of what the ablations look like. I think some of our more recent ablations would show that we get a little more of the mesial amygdala now. One of the nice things about the Monterra system is that you have 2 laser fiber choices. You have what's called a full fire laser, which is a laser that's omnidirectional, where the laser comes out simultaneously from all directions out of the fiber. And then you have what's called a side fire, which is a laser that allows you to rotate the direction of the laser energy, not all the laser energy, but the predominant part of the laser energy. So these traditionally we have used a full fire laser for, which at times, as you might imagine, can limit how much you do if you see that your damage in one direction is getting near things that you don't want to injure, and you have to stop your ablation slightly early so that you don't injure those areas. You might sacrifice some of the areas that you do want to get, meaning leave those areas undamaged. You could use a side fire laser and concentrate your ablation more in one direction to pick up those areas. So we tend to use the side fire lasers often in complex lesions, such as like a hypothalamic hamartoma. We'll use a side fire laser to get multiple directions, giving that we come into those lesions from an angle, and we'll sometimes do those bilaterally with taking the same laser and putting it into 2 trajectories. In a hippocampus, we tend to use the full fire laser for 2 reasons. One, it's simpler, and 2, the full fire laser is actually slightly smaller in diameter than the side fire, and so the parieto-occipital hippocampal trajectory is a small narrow corridor at times, and so we can slip in the smaller laser a little easier. But I'd be interested to hear what other people think about this and what they would do.
So the next patient is a more complicated patient. So this is actually a patient who has what I think is microlepsy. So she presented with a history of déjà vu sensations a good decade ago, and then she also had episodes of migraine, and eventually had a migraine followed by a convulsion. and was found to have an extensive right posterior hemisphere cortical malformation with polymicrogyria and periventricular nodules. We tried her on several medications without success, and interestingly, she actually has a sister we operated before we had laser available with the right hippocampal resection for her periventricular nodules, which she had as well. The seizures are quite interesting. She has the left arm somatosensory aura, then she has a ictal spitting, then the left hemifield visual aura, and has visual spatial coordination, and then she sometimes passes out and goes into a tonic-clonic convulsion. The EEG showed these repetitive sharp waves over the right temporal region, maximum F8, F10, and you can see on her bipolar montage that she has a relatively diffuse, widespread seizure pattern over the right hemisphere at the onset of her seizures. The EEG is the MRI is quite impressive, as you can see. So she has this big ball of abnormal tissue all the way from her left insula, Sylvian fissure, all the way down into her temporal lobe, with almost like a partial schizencephaly in addition to it, and you can see the extent of the malformation. Interestingly, the superior parietal lobe was actually relatively spared from the abnormality. We did a next study which showed that she has two spike population, one somewhat more posterior, coinciding with the posterior abnormalities, and one anterior temporal sharp-wave population. I for a long time didn't consider her as a surgical candidate because of the extent of her abnormalities, and because of people assuming that if you really want to make someone seizure-free, you have to do a total lesionectomy. That changed a little bit with a paper written by Louis Maillard in Annals of Neurology, who basically compiled about 60 patients with polymicrogyria syndromes, indicating that some of these patients could actually do quite well with partial lesionectomies. And that we sometimes actually find the ictal onset outside of the visible lesion. And that by and large, these patients actually did fairly well. The problem with her, though, was that her major goal was obviously that she wanted to go back driving. And any type of extensive resection obviously was endangering not only Meyer's loop, but also Brown's loop, the superior part of the geniculocalculin fibers. And it was even hard on DTI to actually completely understand her visual fibers. It looked like that this bolus of ball of abnormal tissue actually dispersed her fibers with a kind of a very basal track and a superior track, and kind of an absence of organized fibers in the area of the abnormality. So now, it was very difficult to say, looking at these abnormal anatomical images, to really say with certainty that these are the inferior and these are the superior calculin fibers, and that by resecting only the basal part, we would be able to spare her inferior quadrant on the left side. So we did have a relatively good hypothesis that she could be a potential surgery candidate particularly if you would offer her an extensive posterior quadrant resection. But we discussed in patient management that we would try to see if we can localize the seizure onset with invasive recordings better, to see if we can do maybe a visual field sparing resection. So we implanted her with a stereo EEG, and as you can see, the science about this implantation is that we try to skewer as many nodules as we could, including a sheath of nodules which was running just along the lateral ventricle, covered by Y and Z, as well as obviously the extensive nodules in the anterior temporal lobe. I'm not going to show you in detail the invasive evaluation, but it was interesting to see that the most active electrodes actually was electrode C in the mesial part of the abnormality along the lateral ventricle. And there was also the electrode here, you can see that C and M. And we also saw that the ictal onset was started with a nice DC shift and paroxysmal fast, preceded by some repetitive spiking over the C electrode before the patient actually took off and propagated to the rest of the right temporal lobe. So this is illustrating again that the early seizure onset really with repetitive spiking was seen over Z, and then there was a propagation anteriorly. We also did an interesting experiment. We ran visual fields on her for 2 days, recording from each single electrode, and we're able to prove that at least these basal fibers are relevant for her visual pathways, showing these near field potentials as we did visual fields. But we found actually similar findings when we looked at the electrode Y, which kind of piercing through the superior fiber tracks. And again, we were able to find and delineate the visual evoked potentials over this Y electrode, indicating that our theory that probably the visual pathways are kind of dispersed by the abnormality is most likely correct. So we went into and proposed to her 2 different options. One was a limited laser ablation of what we thought was the seizure onset. The other option was an extensive a TPO resection, sparing what we think is visual fibers in the kind of roof of the abnormality. And I think we really left it up to her which one of these 2 options she would choose.
Yeah, I would say that part of our discussion with this family was colored by the fact that Stephan and I have known them for a very long time. As he said at the beginning, you know, the patient's sister was also a patient of ours who had undergone invasive monitoring at one point and an open resection. So this was a family that we'd known for a while, and you know, Stephan had treated both of the sisters for a while, and so this was a long run up to this, you know, to the stereo evaluation, and then we spent a lot of time discussing these options. And you know, while we discussed doing a what would end up needing to be a substantial posterior resection of that abnormal right hemispheric tissue, that whole abnormality was full of some rather large arterial vessels, and it was really hard for us to track them out and try to figure out how much supplied what we were going to remove versus how much of those we were going to be required to preserve so as to not cause extraneous damage by removing that area. Also, I think Stephan's minimizing how much time we spent with our radiologist working on trying to sort out where her visual pathways were. That we really spent a lot of hours trying to reconstruct her pathways and try to figure out where they were. Our neuroradiologists, who are usually excellent at this, put in a ton of time trying to reconstruct them, and it was very difficult because he said one of her goals was to drive again, and she's a completely functional woman, even with her epilepsy.
Josh, do you want to comment on the?
So, you know, in the end, I think that they understood that a large resection was a big deal, and we had talked to them about the fact that we thought that the stereo evaluation had given us at least somewhat of a target to go after with laser ablation that we could take out in a very focal manner as a first step, always knowing that we have larger procedures in our back pocket. And I think that's how they looked at this. What we were able to do was reconstruct those visual pathways, and then I planned a trajectory that both mimicked some of our stereo electrodes where we had those early potentials, as well as try to stay as much as I could out of crossing those visual fibers coming in. Now, I couldn't completely avoid it, but if you look at the axial, I at least tried to stay on the medial edge of them so as to not go straight through them, just because I didn't want to cause any possible issues just with the laser insertion. But using multimodality imaging like this was very helpful in how we plan the ablation and what we did intraprocedurally as we performed the ablation. And so this was our final intraprocedural MRI, and we were able to take out that medial area with the laser in a very, very, very focal fashion, knowing where those visual fibers were, especially at the top of the lesion, and stop the ablation right as we started to get near them on the DTI.
Yeah, so she didn't have any functional deficits. She did well for 6 months. As I said, I joked we should present her after 5 months to make sure she's still seizure free. And then she did have a recurrent seizure, so we kind of will go back and do medication adjustments. Yeah, I think similar experience has been made in patients with tuberous sclerosis complex that neurosurgeons have done multiple trajectories or multiple modules at different times. And I think based on our results, I think it was worth a shot. So the next case is a little bit more, well, similarly maybe contentious, but I think it raises the possibilities of what laser can offer. So this was a 66-year-old right-handed woman with seizures for 10 years. With a large parahippocampal gyrus cavernoma. Again, she has a very typical epilepsy syndrome with psychic aura, automotor seizures, post-tickler aphasia, failed several medications, and is a little bit of a fragile woman with a pre-existing third node palsy on the left, so she can't really see out of that eye. Again, she had left anterior temporal sharp waves and left temporal lobe seizure pattern, relatively typical. And she has this relatively large cavernous angioma in the right underneath the outflow tract of her hippocampus on the left side. And interestingly, she was actually, we recently published a series on patients with early surgery for cavernous angioma. She actually was one out of 6 patients out of 49 patients. We declined to offer surgery for cavernous angiomas because back in 2010 we thought that she was not a good surgical candidate because of the significant risk of causing memory decline. You could make the argument she already has some memory impairment based on neuropsychological testing, but morphologically her hippocampus on the left side looked absolutely normal. So we thought that she would actually be at significant risk of having further decline. Again, she has a left temporal lobe epilepsy with congruent data. And so the discussion in patient management conference was to either do a more extensive invasive evaluation if she's willing to take a hit on her hippocampus, to see if the hippocampus is involved and maybe delineate the surrounding of the cavernous angioma, or do something which we typically try to avoid with cavernous angioma. Usually when we have a cavernous angioma, we try to do a somewhat generous resection and take out all the perilesional schmutz and iron deposition. And then these patients actually have excellent seizure-free outcome in the order of 80–90%. Some of our pathologies with the best outcome. But the other end of the discussion was to say, why don't we offer her the best we can, which is doing a lesionectomy, preserving her hippocampus, preserving the part of the cavernous angioma which encroaches on the hippocampus, and see if you're lucky, and counseling her as having probably a 50–60% chance of that will help her seizure control.
Yeah, from a surgical perspective, we love cavernoma related epilepsy. It's really a very nice lesional epilepsy for us, and as surgeons, it's a very satisfying thing to take out cavernomas and take out the hemosiderin stained brain around it. But this one wasn't in a great location. What we didn't show is that if you look at her sagittal MRI, her left vein of Lebet basically overlies right where that cavernoma is. So if you wanted to go transsulcal, you would be going through her posterior dominant temporal lobe. If you wanted to avoid that and go subtemporal and then come right up into that cavernoma, even with a lumbar drain and CSF removal to soften things up, you'd still end up yanking her dominant temporal lobe right where her vena Lebet is tethered to the transverse sigmoid junction. So it doesn't make it a very easy approach for us or for her in either way. And so that was one of the reasons why we considered laser and discussed this with her. And so there are two possible ways you could get to this. You could get to this coming orthogonally in from the lateral temporal lobe and come through, or you could do what we chose, which is to come into it from posterior like you would for a standard hippocampal ablation, but just a little lower because of where it is. And so that's what we chose. And what you see on the right is the thermal damage estimate overlaid on our post-op MRI, and you can see that not only does the thermal damage estimate pretty much adhere to what the MRI shows, which is one of the nice things about this, is that you always wonder, well, the software makes this little blue thing and says that's what I destroyed. Is it really what I destroyed? But we find that they're actually rather congruent just about every time. It's been pretty amazing. And so we were able to very focally ablate the cavernoma and keep the area of ablation below where her hippocampus and her hippocampal tail was starting to curve up. And she's actually done rather well.
How long is it? How long has it been since the ablation?
So
she is approaching 1 year.
Yeah, so it's 11 months. She had a single seizure in the setting of a UTI and hyponatremia, but has otherwise been seizure-free. And she used to have 2-3 seizures a week.
Yeah, because sometimes we went again afterwards. So I'm just asking about the size and about the area of what you are targeting, and versus small versus larger area.
Yeah, it's not enough outcome data to
yeah, again, we certainly like.
Have you seen a volume change on serial scans post ablation?
A volume change in the cavernoma?
Yeah, so we haven't been able to do a post-operative testing because of COVID. So we typically do a 6 months neuropsych, 24 hours EEG and an MRI. And we have not been able to do that, which would have been in March. And you know what happened in March. So.
Yeah, so we've done a couple, and in both of them, we've seen about a 60% decrease in cavernoma volume over a year and a half from treatment. And both of those patients have done really well. But for me, the worry is counseling about long-term risk of hemorrhage to the cavernoma, and I know it's a low frequency event. How do you approach that?
I mean, theoretically, there shouldn't be much of the actual cavernoma left, right? We put the laser pretty much directly into the cavernoma cavity, and then you're doing high temperature thermal coagulation of those venous channels. We can't tell them that they're cured of their cavernoma, obviously, because we haven't taken it out. But we can tell them that we hope that their hemorrhage risk is lower because we're basically coagulating it.
But it's an interesting question. We actually just discussed the patient in patient management conference with the cavernoma, who's the candidate for stereo EEG because of a different location. And so the approach to the cavernoma with stereo EEG is that you wouldn't probably put your depth electrodes to the cavernoma, but once you decided the cavernoma has to go, you actually put your probe to the cavernoma. So the next case, I think, illustrates another issue. So case 4 is a 28-year-old man who I think he works in construction. He had epilepsy for about 2 decades, shortly after he fell from a horse. questionable loss of consciousness. Again, he has rising abdominal sensation followed by staring and automatisms, and initially rather frequently. Now he still has them about once or twice a week, which doesn't allow him to drive, and he also and he is dependent on it for his job. So really wanted to become seizure-free. His epilepsy syndrome was slightly more complicated by him having bitemporal shock waves, although the more frequent and prominent one were still on the right side. He had 4 seizures recorded in the epilepsy monitoring unit with a nice temporal theta pattern, as you can see on the compressed 20-second trace here. And he had subtle evidence of MTS on the right side, but there was also some concern expressed by the radiologist of some blurring in the basal temporal region involving the perihippocampal gyrus. And that concern was further enhanced by the fact that the patient actually had a rather significant hypometabolism on the PET scan over the right temporal region. So again, the options are to offer him an open resection, a laser ablation, a selective auricular hippocampectomy, or an invasive monitoring. Obviously, in this case, the question is not so much about cognitive decline, because in the right temporal resection, particularly in patients with pre-existing lesion, the risk of that he has any significant cognitive impairment is relatively low. I think it's really more a cosmetic or procedural questions. Is he willing to take a more aggressive craniotomy, or is he would he prefer to do a staged approach and start with a laser ablation? We offered him again both options, particularly because which is kind of psychologically quite interesting. You know, when he first saw me, he was completely opposed to any type of brain surgery. He didn't want to do that, and so as we did the evaluation, I think the idea that there could be a laser ablation was actually what brought him into the epilepsy monitoring unit and motivated him to go through this. But then when he was actually presented with the results and counseled about the different chances of being seizure-free from an open resection versus a laser ablation, he said, I want to have my life back. I think I want to have the best chance you can offer me. And if you think a right temporal lobectomy is the best thing, that's what I would take. Again, there's this little bit of this mixture of patient preference and what we would advise. I have to say that even before I saw the pathology, I think this was not the best case to offer him a laser ablation. I think the blurring of the perihippocampal gyrus, the extent of the fatty hypometabolism are certainly factors to take into account.
What would other people have done? Would other people have offered him a laser at all? Would you not have offered him a temporal lobectomy? Would you have done invasive monitoring?
Well, I think it's interesting how you guys are going to, because it's in the scenario that you described, Stephan, was very similar to kind of what happens. People are like, I'll never do surgery, and then they start thinking about it, they're like, well, maybe laser might be okay, and then by the time you get to the end of the road, then they're all in on the ATL. And it's interesting how I think having several of these options really allows people to think about what's possible. I think it's a less scary jump initially to these less invasive opportunities, and then they end up wherever they end up. I think at KU we would have done probably the exact same thing you did, is take him through the process and then give him his options. And I think there'd have been a lot of concern with a laser in this patient with the blurring, and so we might have said, well, you got your best opportunity with the ATL. I know our surgeon or one of our surgeons is pretty keen on laser, so she always makes a reasonable counseling for them when she thinks appropriate. But I think in this situation, the ATL is kind of his best bet. But it's always better to start somewhere if they're not willing to do the ATL.
Yeah, I mean, I just want to interject. I think it's very dependent. I try to do like LITT, and I think that LITT patients are more readily available for LITT. My mentor for many years, Pete Engel, strongly believes that we should push patients for ATLs and not do LITT in cases like that, because it offers like the a best chance of seizure freedom. And his concern is that if we don't get an optimal outcome, then the patients may not go afterwards for a second procedure. I mean, that's at least the way. So basically what I do is I look for any red flags that might involve, like if there's any FCD or polar changes or anything else that might indicate that the patients would do like a little bit less better. But I'm just saying that it's very dependent on where you go, because there are some other centers that will overwhelmingly use LITT in their approach for a lot of these cases. So it's very, very center dependent.
Yeah, I think that's a great point, that I think every center kind of positions these options differently. We certainly have had people who, even when presented with something like this, the patient would never, ever, 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 ever consider an open operation. And the patient's choice then is, as Patrick said, better to start with something than nothing in some of these folks. But you're right. I think that laser for us has proven to be a way to kind of break the ice with epilepsy surgery with some people and get them to go down the road of a surgical evaluation. And then by the time you get down the end of the road, sometimes laser is still a great choice, and sometimes it may not be the best choice. But at least you've gotten more people to go down the pathway than you would have earlier.
Yeah. So he opted for a straight resection. We usually typically do that under ECOG guidance. We don't really change the resection margin significantly in our evaluation, but I think rarely. But we find it also very useful information to counsel the patient postoperatively and guide medication management. We did not show him that picture before he underwent surgery.
I'm sorry, can I interject for a sec? You put in all those electrodes just for like when people go straight to resection?
Yeah, we typically.
Interesting.
Yeah, so we do 1 or 2 depth electrodes and basal temporal strips and the lateral strip to confirm that and also to match it up with pathology prior to resection. Yeah.
How much time does that?
Yeah, as I say, we've gotten reasonably efficient with this. The depth electrodes are done using frameless neuronavigation, and strips are with my hand neuronavigation. And I would say the depth electrodes take about 15 minutes to put in, and the strips about 3.5. So not really that long. And so we've been able to really do this efficiently so that it doesn't add too much to the total OR time.
No, that's just interesting. I'd love to get more electrophysiologic information, but I'm always cognizant that they're under anesthesia, and our surgeons are pretty chill and easy to work with. But 20 minutes is probably something they do. It's nice to get that info.
Yeah, I don't think you want to go in the OR with making a lot of decision trees about what you find, because I think you're just already very limited, and you should have your plan in place. But I find it very, very helpful afterwards to know the spikes actually did come from the hippocampus, or the spike did not come from the hippocampus. There were actually a perihippocampal gyrus spikes as well, or polar involvement. And I think it helps me to decide which patient can come off medication and which don't. And it doesn't take a lot of time, and it's a lot of fun. Yeah. Okay. So as I said, we did not advertise this, and maybe Dr. Rosenow remembers it better than I do, this that we went through after this procedure.
So the resection was relatively uneventful until he woke up somewhat weak on his left side, but that luckily resolved after about 24 hours, and he's done pretty well since then. So it may have been a little bit of anterior choroidal retraction on my part or something during the mesial resection, but he never had an infarct.
And this was the pathology, so he did have focal cortical dysplasia, and so the MRI findings were kind of actually confirmed and also consistent with our neurophysiology. So he, you know, as I said, we don't know for sure, but we could have assumed that he probably would be in the category of patients who have a significantly less chance to be seizure-free just with a laser ablation by itself. So we, as I said, I have one more case, but I think we are kind of in the 45 minutes we wanted to spend here. I think I have one case which I think is interesting because it's one of the non-lesional left temporal lobe cases where we did a invasive evaluation to kind of make the point that he has a mesial temporal lobe epilepsy before offering him options. Based on the experience, the Columbia group has found that patients who are non-lesional mesial temporal lobe epilepsy actually have similar good outcome if you prove with stereo EEG that they actually are mesial temporal before you offer them laser ablation. So I think there's certainly an avenue to go. Although as in many of these dominant left temporal lobe cases, when you don't have a lesion, you also have a skyrocketing risk of having a cognitive hit from any type of procedure, or cytoreductive procedure. So I think that is something we still have to discuss with the patient. But I think it's interesting to think about it that these patients become candidates for laser ablation if you do a diligent invasive evaluation. So in summary, laser ablation I think is a valuable tool for patients with refractory focal epilepsy to remove the epileptogenic zone and to render patients seizure-free. I think they have to be well selected and often require more detailed understanding of the epileptogenic cortex and the functional cortex than what you would need for an open resection. And the decision is obviously a mix of what you feel is his best chance for seizure freedom, the risk of functional decline, and by and large part also patient preference. I think one thing to what Patrick said before and Dawn, you know, when we started out, we were not that confident and upfront with the patient. Nowadays, I think we just counsel them relatively aggressively if they want to go down the route of laser, that if that doesn't work, there's always the option to go back with an open resection and kind of put that right out there. We just had actually just this week one patient who failed the laser and he just came back in for the EMU and we'll prep him for an open resection. But I think it is important to make that if you go with a staged approach, I think it's important to introduce that idea relatively early on.
Yeah, I think we're still trying to understand the potential rate of seizure freedom with an open resection following laser. I think in the literature there's been some data that says that the open resection following laser doesn't necessarily pick up what the laser fails to get, and there's been some literature that says that it does. So as Stephan said, we have someone that came back in now who failed laser after a while, and so we are reevaluating his epilepsy, right? We want to make sure that where the seizures are coming from now are still the same areas that we had tried to target before.
Yeah, I mean, we've had a couple of patients that were seizure-free after extending the resection, but they had LITT initially. I mean, there are more. I didn't do a systematic review of the LITT cases. We did, but at least a couple of my, you know, just remembering, there were two patients that had become seizure-free following like an ATL after they did have a reduction of seizures with the LITT, but they still had persistent seizures. But I think there is a need actually to look possibly from a multi-center standpoint and just look at these cases and see which cases continue to be refractory and which not. I mean, obviously it depends on where the patients had a phase 2. I mean, they could have missed like an onset, like an insular onset or an onset elsewhere that propagated to the temporal lobe. So then you had like, that's a different reason, but it really depends on whether the epileptogenic region is within the area of the resection, of the ATL resection, or not within the area of the ATL resection.
Yeah, I think that's a good point. As we said earlier, different centers will obviously work people up slightly differently. And it's very important to make sure that when we're offering people laser, that we're not skipping steps in the evaluation, right? Just because we can stick a laser in the hippocampus doesn't mean we shouldn't make sure that maybe insular epilepsy isn't ruled out beforehand in people who we have that suspicion.
And don't get me wrong, I'm a big advocate for LITT. I really think I managed to convince a lot of patients from certain ethnic backgrounds mainly, but not just, that had really, I've tried for years, having them consider resective epilepsy surgery, and they only agreed to LITT. So I totally agree that provides avenues for breakthroughs.
I think it a lot depends on how high the chances that that the patient has a FTD type 3 associated with the lesion. In some of the tumors and cavernous angioma is just relatively high and very difficult to, sometimes you're lucky and you see some blurring on the MRI, but I think the best parameters to tell you ahead of time what patient should probably not go for laser is, I don't think we know them all. And then I think it's similar to medication withdrawal after surgery. There's so much patient preference involved that it's really difficult to study that systematically.
So I had very similar patient with small cavernous angioma or cavernoma, and it's a little bit more anterior than your case number 3. It's more on the interface between amygdala and hippocampus. My question, so I just want to make sure I understood correctly. So when you plan laser trajectory, you will literally spare or go through the angioma, right? Through the cavernoma. You're not trying to skive it and then use either side firing laser or just to kind of hit the angioma leaving on the side of a laser. You go through the angioma. Is that correct?
So in this case, I went into the angioma.
Okay.
But certainly depending on where it is, you can choose to say come below it and then use a side fire to come up into it, right? You could, it really, the trajectory and what you choose should be individualized based on the anatomy of that lesion.
Okay. And how you make a choice how much that hemosiderin stained, obviously you cannot see during laser procedure, but how you choose how much you ablate or that hemosiderin stained or impregnated the brain tissue?
So yes and no in terms of seeing the hemosiderin stain. So you can try to merge in T2 imaging. We have found that the T2s that we do intraprocedurally don't look as great, but you can try that. The other thing you can try to do is see if you can bring in preoperative T2s and merge them in the workstation. But we tried to get as much of that hemosiderin stained area as possible into the blue thermal damage estimate. We really wanted that area more than just warm.
Okay, because
but
in
again,
my case, I'm sorry.
But again, you're balancing it out, right? If this is your area that you want to get and your hippocampus is coming right above it, at some point you might have to compromise some other areas so that you don't damage the dominant hippocampus coming right over the lesion.
Yeah, in my case, it looks like it's hippocampus also sclerotic, but the hemosiderin stained area is pretty large, so I wasn't sure if I should plan another trajectory just to reach other corners of hemosiderin staining, or just ablate from traditional occipital trajectory, get as much as possible hemosiderin stained brain, and then they just observe patient post-op if she has any recurrence.
So depending on how things look, you could try to come from one trajectory and use a side fire if you think that you want to push if it's eccentric in a very specific way. The other thing that you can do is you can do 2 different trajectories, right? So one of the nice things about this system is that you can use one laser fiber and put in 2 bolts and do multiple trajectories. So if you think you can get part of it from one trajectory, but then you're going to sacrifice the other part, you can plan a second trajectory to pick up that other part and, you know, just take the laser out and reinsert it cleanly into the second bolt and get the rest of that area without having to use more laser fibers or to do much more work.
Any technical advice using same laser for 2 or more trajectories to keep it as sterile as possible? Do you have any tricks, any advice?
So when we have done multiple trajectories with the same laser, so we have we have 2 Monterra systems at 2 different hospitals, but the one where Stephan and I are together, we don't have an intraoperative MRI. So we actually put the bolts in the OR and then take the patient down into general anesthesia to the diagnostic MRI, and then put the laser in the diagnostic MRI. So we've created a system down there where we actually create a sterile back table, so that we're handling the laser sterilely. I would say that if you are going to do more than one trajectory, it's probably reasonable to take additional sterile precautions, meaning you have to make sure that you cover the bolts before you leave the OR sterilely, and then I would not uncover the second bolt in the MRI until you're ready to use it. That way it stays covered and sterile. You should probably not just glove, but you should probably gown up and put a mask on as well, just because you will be doing the transfer of the laser. It won't just be one insertion and then take it out and throw it out. And I know some people have also, before they've put a second laser in, we haven't done this, but I know some people that have cleaned the second bolt surface with maybe some chlorhexidine, like a little Duraprep, not Duraprep, like a little one of the clear Chloropreps, and let it dry, not in the bolt, but just the outside of the bolt. You don't want to put it in the bolt because you don't want to put a chlorhexidine laser in there. I don't know that you should do that. I don't think that is probably too kosher with the laser, in case you get some chlorhexidine on the laser. So I wouldn't tell you to do that. But I know I've heard people that have done that. I think if you just stay clean and just get the second bolt ready before you take the laser out, and take the laser out cleanly, remeasure it, because you'll have to remeasure it for the second trajectory, and then just go right back into the second bolt, which is how we've done it, you should be fine. The main thing is to just keep everything as clean as possible, and again, like keeping that second bolt covered until right before you use it.
Thank you.